Dictation patient Hernandez, Hernandez, Elżbieta, Elzbieta. Please address it to Dr. Takar, Takhar, initial A, paragraph, date of visit, MAR 18/19, paragraph, presumptive diagnosis, presumptive diagnosis GCA, paragraph, meds, Nexium, metformin, Januvia, stop, she is off prednisone, paragraph, interim history, Elżbieta gradually discontinued prednisone and has no recurrence of headaches. Her blood work done on March 4th showed ESR 14, 14, negative RF, elevated ALT, ALP at 174 and 182 respectively, and elevated hemoglobin A1C. Her CRP was 15.5. Stop. Stop and paragraph. Impression. I discussed with her results of laboratory investigations. At this point, laboratory investigations, since she has no recurrence of headaches, I'm not concerned about possibility of GCA. Stop. She was given requests for follow-up blood work due to her elevated liver enzymes. I send this copy to your attention. If this is not going to resolve, you may choose to consult one of the gastroenterologists for additional opinion. Stop. On the other hand, if Elżbieta would suffer a recurrence of her headaches, she was advised to contact my office. Stop on patient Christensen. Christijanson, first name Lisa, Lisa. Please address it Dr. Hannon, Hannon, initial P, paragraph, date of visit, MAR 18/19, paragraph, diagnosis in question, spondyloarthropathy, paragraph, past medications used in the past, Vimovo, diclofenac, and Indesit. Stop. No history of psoriasis, IBD, or uveitis. Paragraph. Past HX, invasive ductal CA, MAR /1A, treated by lumpectomy, chemotherapy complicated by febrile neutropenia. Stop. Hypothyroidism, stop in left kidney. Stop. Left hip arthroscopy, in brackets, Dr. Ayeni for labral tear, close the brackets, paragraph, meds, tamoxifen, period, and Synthroid, paragraph, allergies, sulfa and sulfasalazine, paragraph, interim history. Dr. Christensen had laboratory investigations done which showed negative RF, CRP 0.6, ESR2, normal CBC, normal differential count, normal TSH, T4, T3, and T4 free, ALT, ALP, ferritin 51, normal vitamin B12 at 631, creatinine 59. Stop. Ultrasound of Achilles tendons showed a moderate bilateral tendinosis of the mid portion of the Achilles tendons with no evidence of enthesitis. There was also no evidence of synovitis in either ankle joints. X-ray of the spine and SI joints revealed degenerative changes, especially DDD at C5-6 and C6-7 level, as well as L2, L3. Stop MRI of the spine and sacroiliac joints showed again degenerative changes in a similar location with no evidence of inflammation in the spine or either sacroiliac joints. MRI of SI joints also showed no evidence of erosions consistent with previous inflammation. Paragraph, Dr. Christensen is remaining on diclofenac 100 milligrams once a day, and the most severe pain she's experiencing is in her Achilles tendon, and she has difficulty walking. Paragraph, X-ray of her both hips showed only very mild OA. Paragraph, impression I reviewed with Dr. Actually, before we say impression, she also is struggling with protracted fatigue and has increasing difficulties being on call on a regular basis without proper sleep at night. She also finds that stress is adding up to her symptoms tremendously. Paragraph, impression I reviewed with Dr. Christensen results of her investigations. At the present time, she does not have an active spondyloarthropathy that would require treatment with one of the biologic medications. It seems that the pain related to Achilles tendinopathy is the most significant problem, and I referred her for physiotherapy treatment with shockwave therapy, and also gave referrals for a massage and osteopathic treatment. She will remain on current dose of diclofenac and will have follow-up blood work done in April. Lastly, I also referred her to Dr. Christopher Wu, W. orthopedic surgeon in Milton, regarding this problem for another opinion. Lastly, I strongly recommended that she's no longer doing call and has less stressful lifestyle. Paragraph, F/UP 3 to 4 months or sooner if needed. Vira, V-I-R-A, Natasha, N-A-T-A-S-H-A. Please address it to Dr. Holler, H-O-L-L-E-R, initial T. And send a copy to Dr. Dhiraj, D-H-I-R-A-J, initial N, paragraph. Thank you for referring Natasha, who is 27-year-old pharmacist. Regarding possible relapsing polychondritis. Paragraph, she has been experiencing recurrent attacks of pain and redness over both ears. This has been occurring for several years, and attacks are quite frequent and occur on a weekly basis. She did not have any picture to show me. She had one picture that illustrated the problem. She has been using quite sporadically naproxen, which is not very effective stop. She is otherwise quite well and has no history of recurrent rashes, shortness of breath, cough or chest pain. She also has she does not recall. She also has no symptoms of pain in the nose or nasal collapse. Stop. She has no ocular symptoms, no history of hoarseness of voice or non-productive cough. Stop. She has no known history of cardiac issues. Stop. Her hearing has not been affected, and apparently examination of her airways with the camera has been quite normal. Paragraph. She is otherwise extremely. She's otherwise completely well. Paragraph. Current medications: ALES and naproxen, PRN. Paragraph. Allergies to medications: none. Paragraph. FHX. Mother. Migraines, depression and anxiety. Father died at 53 from extremely severe ulcerative colitis. He had a history of uveitis and back pain. Paragraph. Natasha is non-smoker. She works full-time in various pharmacies. Paragraph. Physical exam today revealed BP 122/17. No pedal edema, no evidence of rashes, no thyroid enlargement or lymphadenopathy, normal heart sounds, no added sounds, murmurs or rubs, lungs clear to auscultation. MSK exam revealed no synovitis. Paragraph. Impression. Natasha presents with several year history of recurrent erythema of both ears. This is quite characteristic for relapsing polychondritis. I requested information. I requested blood work that she recently had with you, and if I will need any additional investigations, I'll call Natasha. I also place her on Celebrex 200 milligrams twice a day to treat it, and she was asked to try it for a while regularly. Stop. I will review her again in July and will discuss, if needed, other treatment options. Stop. She agreed with this plan. Stop. Anna Jeruszyńska. Patient Campbell, CAMPBELLUTUTE, initial M. Please address it to Dr. Morris, MORRIS, initial G and S. Paragraph. Thank you for referring Uti, who is 77-year-old female. With respect to possible inflammatory arthritis. Stop. And paragraph. Uti's symptoms started sometime in January of this year, fairly abruptly. She has been experiencing stiffness and pain around both shoulders and neck, and then she developed stiffness and swelling in both wrists and possibly MCP joints. She feels quite stiff in the morning and has difficulty mobilizing. Her energy level went down. She has no history of headaches, symptoms of jaw or arm claudication, and no diplopia. Paragraph. She has history of HTN and mild depression. There is no history of rashes, including psoriasis, IBD, or uveitis. Stop. She has no symptoms suggestive of Raynaud's or Sjogren's. Paragraph. She is a chronic smoker. Paragraph, medication, Zoloft 50 mg OD, Atacant 8 mg OD, Celebrex 200 mg OD, and vitamin D 2000 IU/day. Paragraph, allergies, none. Paragraph, physical exam, BP 124/70, no pedal edema, no rashes and no rheumatoid nodules, normal heart sounds, lungs clear to auscultation. MSK exam revealed joint line tenderness and stress pain in both shoulders as well as both wrists. There was evidence of synovitis in both wrists, right first, second and third, and left first and second MCP. Paragraph, blood work from January showed ESR 12, CRP 54, platelets 451, normal CBC and negative ANA. Paragraph, impression, UT has evidence of PMR as well as inflammatory arthritis. She was placed on prednisone 25 milligrams per day as well as Actonel DR 35 mg OW to prevent GIOP. She was also referred for baseline bone mineral density testing and additional blood work today, which will include anti-CCP to rule out possibility of early RA. Stop. She was given another requisition to do blood work monthly, and I will review her at 4 to 6 weeks. Stop. Thank you for referring this patient for consultation. Manley, MANLEY, Michael, MICHAEL. Please address it to Dr. Chung, CHUNG, initial K and L. Paragraph, thank you very much for referring Michael, who is pleasant 69-year-old male, with respect to possible RA in view of his positive RF at 41. Paragraph, Michael has several medical problems, including history of diabetes, diabetes as well as benign prostatic hypertrophy, history of skin lymphoma on the right forearm, as well as osteoarthritis affecting both knees, and also history of meniscal tear in the left one, where he had two arthroscopies, and back pain. Paragraph, he has not been experiencing any joint swelling or significant stiffness, especially in his hands, wrists, including MCP and PIP joints, or in his feet in the MTPs. Stop. He also has no history of rashes, IBD or uveitis, and no symptoms suggestive of either Raynaud's or Sjogren's. His level of energy is well preserved. Paragraph, current medications: insulin, metformin, Januvia, Avodart, Flomax, Myrbetriq, Miacardis, Remeron, Ciprodex as needed, Tramadol as needed, Ativan as needed, Lasix as needed, Arius as needed, and cortisone cream. Paragraph, allergies, adhesives, acrylates, penicillin, amoxyl, sulfa, sulfites, polysporin, latex, and environmental. Paragraph, he also has history of tinnitus on NSAIDs. Paragraph, physical exam reveals significantly elevated BMI. Vitals were not tested. No thyroid enlargement. Normal heart sounds. Lungs clear to auscultation. MSK exam revealed minor OA at some DIP joints. None of the joints were tender or swollen. There was no evidence of synovitis. He had mild pedal edema edema and was wearing compression knee heights bilaterally. Paragraph, blood work, RF41, ALT63, ESR7, anti-double-stranded DNA negative, normal TSH, normal CBC and platelets. Creatinine 84, hemoglobin A1C 8.2. Paragraph, impression. Michael has no evidence of inflammatory arthritis on clinical examination. He does have evidence of OA. Stop. He was referred for additional blood work, which include anti-CCP testing. I will contact him in case of any concern. Stop. Thank you for referring this patient for consultation. WORRALL, Robert, ROBERT. Please address it, Dr. Vora, VOHRA, initial A, paragraph. Thank you very much for referring Robert, who is 67-year-old female with respect to painful CMC joint. Stop. He has been experiencing pain primarily over left CMC joint since summer of last year. Robert is professional big pipe player and he plays daily. He's also teaching. Stop. He has noticed pain at the base of the left thumb and much less so at the right as well. Playing can be uncomfortable and pain can occur afterwards as well. He does not believe his dexterity is impaired at the present time. He has been attending physiotherapy for a couple of months with no obvious improvement. Stop. He never experienced any significant swelling in any of his joints. He tried glucosamine sulfate and he feels that perhaps it's making some difference. Paragraph, he has history of hypertension and that's treated. Paragraph, current medications, glucosamine sulfate 3 tablets/day and Ramipril. Paragraph, allergies none. Paragraph, FHX, both parents died of cancers. Paragraph, physical exam, BP 122/70, no pedal edema, normal heart sounds, lungs cleared, auscultation. MSK exam revealed minor joint line tenderness and stress pain over right CMC joint and more significant on the left with decreased mobility and stress pain. There was Finkelstein test was negative bilaterally. Paragraph, X-ray describes OA, shows OA, moderate OA, moderate to severe OA at left first CMC joint with no erosions or juxtaarticular osteopenia or new bone formation. Ultrasound showed no tendinitis. Paragraph, impression, Robert has OA affecting CMC joints of both hands, with left CMC being much more symptomatic. He was given prescription and advised to wear thumb splints every night. He may also inquire about softer splint to use when playing big pipes. When playing pipes. Stop. He will use Tylenol, extra strength or arthritis pain, and I also prescribed diclofenac 10% cream to use up to 4 times a day. If this would not ease off his pain, I can inject his left CMC with cortisone. Stop. He agreed with this plan. Stop. Thank you for referring Robert for consultation. Stop. Sims, SIMS, Donald, DONALD, initial V. Please address Dr. Inkster, INKSTER, initial J. Paragraph. Thank you for referring Donald, who is 46-year-old man. Who has diagnosis of AS. Stop. He is known to be HLA-B27 negative. He has AS for minimum 10 to 15 years and has been treated with Remicade since 2010. Prior to it, he received ibuprofen and other anti-inflammatory medications and possibly even prednisone. He also recalls being on methotrexate methotrexate at one point. Remicade has been extremely effective for him. However, he has not received Remicade since November of last year. I'm not quite sure what exactly happened and why he was not treated. He admits having two previous rheumatologists in the past. Paragraph, he has no history of IBD or uveitis and has no symptoms of peripheral joint pain, swelling or stiffness. He has been tolerating Remicade very well. Paragraph, he is a former smoker who quit about 4 to 5 years ago. Paragraph, in the last month, he has been experiencing 30 to 45 minutes of morning stiffness. He also can wake up at night being in pain or stiff in his spine. He has a previous history of alternating buttock pain, but currently has no pain or stiffness, and comments on the fact that his both SI joints are fused. Stop. He has no history of psoriasis, IBD, or uveitis. Stop. And paragraph, current medications, Tylenol 3 or Oxycodone, PRN. Paragraph, allergies, none. Paragraph, no history of PUD, IBD, or uveitis. Paragraph, FA allergies, none. Actually, sorry, I said allergies, none, no history of PUD or GI bleed. Paragraph, FHX. Question mark AS grandma. Paragraph, physical exam BP 122/70, no pedal edema, no rashes or nail lesions, normal heart sounds, lungs clear to auscultation. MSK exam reveals significantly decreased range of motion throughout the spine with wall tragus distance 23 cm, modified shoulders 11.5 cm, well-preserved mobility in shoulders and hips with no evidence of synovitis, dactylitis, or enthesitis. Stop. Wall tragus distance 23 cm, modified shoulders test 11.5. Weight 235 pounds, chest expansion 3 cm. Paragraph, impression, Don has a long-standing history of AS and has significant limitation in mobility of the spine resulting from damage. He was referred for relevant x-rays as well as blood work, and I will renew his Remicade right away. Stop. He agreed with this plan. Stop. F/UP 4/12. Patient Walsh, WALSH. Laura, LAURA, initial A. Paragraph, thank you very much for referring Laura, who is 51-year-old female with respect to possible psoriasis or psoriatic arthritis or connective tissue disease. Paragraph. Laura has tested positive for ANA 1/320 in a speckled pattern. And this test has been done due to ongoing pain in the joints associated with some stiffness, usually about 15 minutes in the morning. She has never experienced any obvious joint swelling. She has no stiffness or pain at night. She suffers from occasional heartburn with no dysphagia or changes in bowel habits. She also has a Raynaud's phenomenon for years, however, never experienced digital atrophy or ulcerations. Stop. She has chest pain most of the time and is known to have history of CAD with extreme narrowing of LAD, and she had a stent put in place. Stop. She has some dryness in the mouth with no significant dryness in the eyes. Stop. Also, about 2 or 3 weeks ago, she developed redness over both cheeks. which never completely goes away. It has not been precipitated by sunshine exposure. She has no history of nasal or mouth ulcers, no history of DVT, pulmonary embolism, seizures, or psychosis. She has 3 children and had 1 miscarriage between the second and third, and also after third one she had another miscarriage as well as ectopic pregnancy with a twin in utero. Paragraph. She has hypertension. Paragraph. Current medications: Plavix, Coversil, ASA, Lipitor, 40 mg OD, and Tylenol, usually extra strength, 2 tablets BID. Stop. And paragraph. Allergies: none. Mother, family history: mother breast CA, father well, no history of CTD, RA, or other autoimmune diseases. Paragraph. Laura also had renal stone and has been seen by Dr. Bandal. She also has history of tonsillectomy as a child. Paragraph. She is a non-smoker. Paragraph. Physical exam. BP 122/70, no pedal edema, no rashes, no rheumatoid nodules, normal heart sounds, lungs cleared, auscultation. MSK exam showed minor OA affecting her hands with no evidence of tender or swollen joints. Paragraph. Blood work: negative RF, ANA over 160, negative RF, CRP 1.5. Paragraph. Impression. Laura presents with history of arthralgias, face rash, long-standing history of Raynaud's, as well as heartburn, and in view of abnormal ANA serology. She also has more joint pain, which can be resulting from her OA. Stop. She needs additional laboratory investigations, and she was referred for those. She will also complete x-rays of hands and wrists, as well as the left hip, along with ultrasound where she has intermittent pain. Lastly, she will have x-rays. Stop. I will review her at 5 weeks' time. Stop. Anna Jeruszyńska.